Overview of renal tubular processing across the proximal convoluted tubule and the loop of Henle. We will be looking into the different substances being absorbed and secreted across these segments of the tubule, as well as the related applied concepts. So starting from the processing across the proximal convoluted tubule, first, let's look into the characteristics of this segment of the tubule. It has a very good brush border at the apical membrane, extensive mitochondria to apply for the energy for the very high reabsorptive capacity of this segment of the tubule, plus an extensive labyrinth of intracellular and basal channels to provide a passage for the reabsorption of these substances. Also, it has a special role to play in the glomerulotubular balance that we will be discussing when we will be having a session on the regulation of renal tubular reabsorption. Proximal convoluted tubule reabsorption is in front of you. You can appreciate the reabsorption of sodium, glucose and amino acids from over here. Also, there is some reabsorption of proteins by pinocytosis, chloride mostly in the distal half, and also it is freely permeable to the water. All the absorption occurring in the proximal convoluted tubule is going to be isoosmotic. As much as the solutes are being absorbed, the water will be following it. Secretion, you can appreciate in this image of hydrogen ions occurring by the counter transport over here. As you can see the co-transport of glucose and amino acids over here. To look into the further details of the channels involved, glucose is being transported by the sodium glucose co-transporter, particularly type 2 in the proximal half of proximal convoluted tubule, whereas only 10% glucose is reabsorbed in the distal half of PCT by the sodium glucose co-transporter 1. Whereas at the basolateral, it is labeled wrong over here. This was the luminal border and this is the basolateral border. So the facilitated diffusion at the basolateral border is occurring by the glucose transporters, majorly by the glucose transporter 2 in the proximal half and type 1 in the distal half of the PCT. Water reabsorption is having by a very high permeability across this, and this is an isoosmotic reabsorption. Aquaporine ones are involved for reabsorption of water across the luminal as well as the basolateral border, and 60 to 70% of filtered water is reabsorbed at the level of proximal convoluted tubule. As you can appreciate the isoosmotic reabsorption occurring over the proximal convoluted tubule over here. The secretion of substances like organic acids, bases, bile salts, oxalate, urate, catecholamines, toxins, drugs like penicillin, salicylates, para-aminohipporic acid, all being secreted at the level of proximal convoluted tubule. The reabsorption of bicarbonate or secretion of hydrogen ions is stimulated by the carbonic anhydrase mechanism at the level of proximal convoluted tubule, and the action of the carbonic anhydrase enzyme, which is inhibited by the carbonic anhydrase inhibitors, a type of diuretic, which indirectly impacts the excretion of the hydrogen ions as well. This is showing the tubular fluid to plasma concentration across the length of the proximal convoluted tubule, which is increasing as increasing for the substances which are not being absorbed much and decreasing for the substances which are being completely absorbed. For example, amino acids and glucose are completely absorbed in the proximal half of the PCT, so their tubular fluid to plasma concentration is much low by the end of the proximal tubular length, and same goes for bicarbonate. Sodium and water are absorbed approximately the same amount, and the osmolarity seems close to the plasma osmolarity, so the concentration ratio is approximately the same. Urea and creatinine are absorbed less, rather secreted, so their concentration in the tubular fluid to plasma, it is rather increasing across the length of the tubular segment. Summary of proximal convoluted tubule. Proximal half, you can appreciate this is the luminal border, and this is the basolateral border, and you can appreciate the secretion of hydrogen by the carbonic anhydrase mechanism over here, as well as the movement of the sodium and potassium, reabsorption of the glucose by the secondary active transport, and on the other end by the glucose facilitated diffusion. In the distal half of the proximal convoluted tubule, you can again see the secretion of hydrogen by the sodium hydrogen countertransport as well as by the chloride base countertransport, which is helping in the reabsorption of the chloride, and also this is simply diffusing across the chloride channels or going through the chloride potassium co-transport from the basolateral membrane. As we previously mentioned, that the chloride reabsorption is occurring more in the distal half of the proximal convoluted tubule. In this image, you can see the secretion of different substances, for example, alpha-ketoglutarate, organic anines across the proximal convoluted tubule. Also, this is showing excretion of certain cations across the proximal convoluted tubule by the secondary active transport mechanism. Now, moving on to the processing across the loop of Henle, and we will be looking into the details across the different segments: thin descending, thin ascending, and the thick ascending limb of the loop of Henle. As you know, this is the descending limb of loop of Henle, then thin ascending, and then the thick ascending loop of Henle. So, if we compare the epithelial cells of these three segments, the epithelial cells in the thin segments, of course, are thin, and thick segment has thicker cells. The thin segments have no brush borders and fewer mitochondria, whereas the thick ascending limb have higher metabolic activity, so abundant mitochondria. Solutes are moderately permeable, including urea and sodium across the thin descending limb, but this is highly permeable to water. 20% of the filtered load of water is going to be absorbed in the thin descending limb, whereas the ascending limbs are virtually impermeable to water. The thin ascending limb is having much less reabsorptive capacity to solutes as compared to the thick ascending limb, which has a good reabsorptive potential for sodium, potassium, and chloride. About 25% of filtered load is going to be reabsorbed over here. So, because of this characteristic of different segments of loop of Henle, this has a very important role to play in maintaining the hyperosmotic medullary interstitium and producing concentrated urine that we will be discussing in a separate session. This image is showing the reabsorption across the thick segment of the ascending loop of Henle, especially to point out this channel, sodium potassium 2 chloride NKCC2 channel, which leads to the active transport of sodium, potassium, and 2 chloride channels via the luminal border of thick ascending limb of loop of Henle, and the excretion of hydrogen by the sodium hydrogen ion countertransporter. Once the potassium, sodium, and chloride are reabsorbed over here, you can see the sodium is entering into the interstitium by this sodium potassium ATPase. The chloride is simply diffusing to the interstitium down the concentration gradients by this chloride channel K beta, whereas the potassium ion, when enters into the cell, has a good concentration difference not only with the interstitium but also with the tubular lumen. So it back leaks via the leaky channels not only into interstitium but also into the tubular lumen. The channels involved are Romke channels and the big potassium channels, which are providing the leaky diffusion of potassium across the renal tubular cells into the interstitium and the tubular lumen. This back leak of the potassium ions into the tubular lumen, that creates a positive potential of about plus 8 millivolts. This plus 8 millivolts become a potential factor to allow for the solvent drag of the cations particularly, and pushing them via the paracellular diffusion into the interstitium, including the sodium, potassium, calcium, and magnesium. So simply by the backlick of this potassium, this positive potential got created, which led to the paracellular reabsorption of these cations. Also, the loop diuretics, including furosemide, ethacetanic acid, butyramide, are going to inhibit this sodium potassium chloride channel, thus leading to decreased absorption of sodium, potassium, and chloride. And by inhibition of this channel, they also lead to hampering of this potential. And when this potential is not there, the reabsorption of these ions by the paracellular transport also gets hampered. So the calcium also starts leaking into the urine in addition to the sodium and potassium. With related to the clinical aspects, there is a disorder named Dent disease, which is particularly related to the defective chloride channels K beta involved over here. If these are defective, the chloride is not going to be reabsorbed over here, rather lost in the urine, and this can also lead to decreased reabsorption of the calcium, causing hypercalciuric kidney stones. Bartter syndrome is another genetic mutation with the channels involved in thick ascending limb of loop of Henle, either with sodium potassium 2 chloride channels, ROMK channels, chloride channel K beta, or Barton protein involved in reabsorption of the chloride. So with the defect of any of these, ultimately the patient would present with the chronic sodium loss in the urine and the hypovolemia, loss of calcium in the urine, and we label it Bartter syndrome. Polycystic kidney disease is again a genetic disorder in which the renal parenchyma is progressively replaced by the fluid-filled cysts and ultimately can result into the renal failure. The problem over here is a genetic mutation of polycystic kidney disease 1 or 2, and it is a calcium receptor that activates non-specific ion channels, and mutation can lead to polycystic kidney disease. Summary of thick ascending limb of loop of Henle: most important sodium potassium 2 chloride, then the potassium leak channels, then the Barton protein involved with the chloride channel, chloride absorption, potassium chloride co-transporter, hydrogen secretion via the sodium hydrogen counter transporter, and then the paracellular diffusion of sodium, potassium, calcium, and magnesium. Effects of loop diuretics we have seen. I hope you can also appreciate the impact on the acid-base status after you have seen this image, and we will be having a detailed discussion on their diuretic section in a separate session as well. So let's revise quickly. Bowman's capsule is for filtration. Proximal convoluted tubule, there is reabsorption of almost everything: sodium, glucose, amino acids, chloride, potassium, magnesium, secretion of hydrogen and organic acids. Descending limb is going to absorb very less sodium and urea but is highly permeable to water. Thin ascending limb, very low reabsorptive capacity. Thick ascending limb, sodium, potassium, chloride, calcium being reabsorbed, hydrogen being secreted. Water is only filtered in Bowman's capsule. Equal salt and water reabsorption in PCT. More water being reabsorbed in the loop of Henle descending limb. Virtually impermeable in the ascending limb, either thin or thick. Osmolarity of the content ultimately is isoosmotic in Bowman's capsule and PCT. As loop of Henle descending limb is reabsorbing more water as compared to the salts, ultimately the content will become hyperosmotic, whereas the ascending limbs are reabsorbing only the solutes, but the water is being left behind, so the content will become ultimately hypoosmotic with more water and less solutes. And this is showing the summary of the channel proteins involved. We have seen in detail with the images previously. So I hope that covers, and this is showing the summary of the percentage filtered being reabsorbed. Proximal convoluted tubule approximately absorbs 67% of the sodium and water. Loop of Henle 25% of it. Distal tubule 5%. Late distal collecting tubule 3%, and also there is action of certain regulatory hormones that we will be discussing in a separate session. Percentage of water being reabsorbed: proximal tubule 67%, loop of Henle 15%, not being absorbed in the distal tubule, and 8 to 17% in the distal tubule and collecting segments. That's all about the proximal convoluted tubule and the loop of Henle. Thank you very much.